All right, so in this video, I'm going to be covering group experimental designs. Some of the main things that I'm going to try to hit on here are strategies for maximizing the effectiveness of research by minimizing risks to validity. In any type of experimental design, I'm hoping that you have the takeaway of the importance of validity and the accuracy of our measurements. Because without validity and without measuring exactly what we're intending to measure, the findings and generalizability of our study really doesn't hold up. I'm also going to cover true experiments for testing causal hypotheses. So in the previous video, we talked a lot about causality. One of the strengths of true experiments is that we can actually give some kind of insight into causal relationships that we can use to hypothesis test. I'll also cover the most well-regarded forms of true experiments, as well as their strengths and weaknesses, and hit on the main differences between true experiments and quasi-experiments. So the material on this chapter, again, is going to be covering the chapter 7 of the ENS book, Group Experimental Designs. So something you should be aware of is the difference between internal validity and external validity. And by controlling too much for internal validity, we might have some threats to external validity. So when researchers try to improve their internal validity, they try to reduce potential threats to validity through sampling measures. So one way to do that is through randomization to make sure that people have equal chance of being selected and there's no systematic bias that's leading to oversampling of one group and undersampling of another. Another way to improve validity is by having a comparison group. So if we're only testing a hypothesis with one group, potentially introducing another variable, maybe we could think of like introducing an intervention and seeing how a group of people respond to that intervention. And we could say, yeah, by implementing this intervention to improve study habits, we can clearly see that this group has improved their GPA overall. But without having any group to compare that to, maybe another group that didn't have any type of intervention, which could be like a control group or a comparison group that had a similar intervention but a different intervention, by having extra groups to compare our intervention to, by having at least one or two other comparison groups or a control group, then we can say with more certainty that there's a causal explanation for the changes in our outcome variable. And also that last point, talking about requiring attention during experiment, this is addressing some issues such as attrition or dropout, group contaminations where maybe one group talks to the other group about what their experience was like with the intervention, expectancies of the experimental staff. So sometimes we'll talk about double-blind procedures where neither the experimenter nor the participant knows which group they're in. By doing that, we can kind of minimize the risk of experimenters kind of giving subtle cues of how the respondent should react or respond, or what kind of answers they might want. Likewise, another threat to internal validity is like a placebo. So sometimes people may improve just by the fact that they're participating in some type of intervention, whether or not it's a true intervention or whether it's a placebo. And in practice, you might think that that's not necessarily a bad thing, but within research, it can cause us problems because we might come to conclusions that aren't necessarily true. With regards to external validity, this is really kind of focused on our generalizability of our finding. Like, can the findings from our study be compared or be applicable to a different population or people in a different setting? So again, with randomization, we can kind of prevent selection biases from contaminating our data or making them less generalizable. But there's another error that is kind of impossible to avoid, in that people self-select to participate. So we talked about in our ethics chapter that people need to be given informed consent to participate. And just by the fact that people who are participating are ones who are already probably more motivated and met certain criteria for participation, such as a certain level of cognitive functioning, for instance. A way to get around that is to try to do multi-site studies. So I can think of, in my dissertation, I did all my data collection within one facility, which really limits the generalizability of the study. So all I can really talk about is what I found within that one hospital. Versus if I would have done multiple hospitals, I could compare my intervention across the different sites and maybe have a little bit more confidence in the generalizability of my findings. And then the last point here is reactivity. A lot of times people change their behaviors or their habits just by the fact that they know that they're being watched or that they know that they're being monitored. And again, in real world practice, sometimes that can be a good thing because people might want to change their bad habits, maybe caffeine consumption or alcohol consumption, because they know that they're being monitored and they have to tell somebody about it. And that can feel kind of intrusive, and people might be likely to change the way that they're responding. So that can be a powerful clinical tool. But in research, you can kind of see how that might be a threat to the validity of your study. So some of the threats that the textbook talks about, secondary to reactivity, is interaction of selection in the treatment group and multiple treatment interferences. And so again, if somebody knows that they might be part of an intervention group, they might be more likely to respond in a certain way. That's a real threat to the generalizability of our study. So again, in order to improve internal validity, randomization is a really key term here. So randomization into 2 or more subgroups at the start of the experiment. So I've certainly seen researchers in the past make this error to internal validity of selecting the first handful of participants to the treatment group and then people who didn't meet certain criteria to the control group. And through doing that, that really negates the findings of their study, because then there becomes a systematic bias for why participants are in the treatment group compared to the comparison group. And a comparison group really helps to decrease the potential problems of history, maybe people being different before they even began the study, testing, or repeated testing, giving repeated answers or similar results, problems with the instruments or the measurements themselves. Maturation would just be people getting better naturally over time. Or maybe if you're thinking of like an educational type of intervention, just like through the natural process of time, particularly when you're working with children and adolescents, they might mature more throughout the study. And by having randomization into different groups, we can really help control for some of that. Also, statistical regression or regression towards the mean, kind of regression towards the average, and secular drift. So just to spend a little bit more time talking about external validity or generalizability of findings. Certainly this is a big issue within any kind of experimental design, because we want to see if our study's findings can really be generalizable to different settings or a different population. So researchers might want to know if their findings hold true from their sample to a different sample. So one way of doing that, like I just mentioned, was doing multiple site studies to see potentially multiple hospitals or multiple schools or multiple neighborhoods in order to see if there's similar results with different populations or slightly different settings. And just a diversity consideration is, do the demonstrated results hold true with different populations? So within our sample, we spent a lot of time harping on the importance of having a representative sample. Part of the reason for this is we want to see if the study holds true with different subsets of a population or of a sample, and if it could be replicable with somebody in a different setting or maybe different cultural or different geographic setting. And researchers also want to know if the intervention might hold true under different conditions. So that's that relationship between internal and external validity. So with internal validity, we want to make sure that we can have a strong enough, well-controlled study that we can have the confidence to say that there's causality by introducing a new variable. Is that what was causing the change in a person's behaviors or mood or attainment or whatever it may be? But by controlling too much in a study, then our findings can't really be generalizable to different settings. So there's kind of like a give and take between internal and external validity. So some features of true experiments: there should be an experimental and a control group or a comparison group, establishing an empirical association between independent and dependent variable. So again, without a group to compare to, we really can't empirically prove that there's the relationship that we're hypothesizing between the variables. Again, randomization, just keep hitting on it. The thing that differentiates a true experiment from a quasi-experiment is randomization. So the ability to conclude that the results in the experiment group are due to the intervention itself and not any of those other extraneous variables that I just mentioned earlier. And a pre-test and a post-test is also necessary, because otherwise, if we're just doing a one point in time, we can't really show the time-related impact of our study and of our intervention. So some of the different types of true experiments are just like a simple pre-test, post-test. In order to meet the criteria for a true experiment pre-test, post-test, you would need to randomly assign participants to one of two groups, taking in observations of the dependent outcome variable prior to the intervention, implementing the intervention, and then again measuring that dependent variable after the intervention. So you could think of an example of randomizing somebody to two different groups for smoking cessation, measuring the number of cigarettes that they smoke per day prior to the intervention, then implementing the intervention, whether it be like a cognitive assessment or maybe a medicinal treatment, and then measuring them again at post-treatment. And then you can do a two-group comparison. There's also a post-test only control group design where we're doing a comparison of the treatment group and a control group but only after the intervention. One of the benefits of that is that there's a threat to the internal validity if somebody is tested too often. So just by doing the one test, we kind of control for that variable. But you could also imagine that there's some limitations of doing that study design as well. And then there's a Solomon four-group design, which is essentially like a hybrid of the both of them. Used when researchers want to test whether there's a test-treatment interaction, and it combines a pre-test, post-test, and post-test only design to understand all possible relationships. So that one's a little bit more complicated, takes a lot more time and resources, but also has a little bit more clinical strength. So some of the difficulties that you could probably imagine with a true experiment is that it takes a lot of time, effort, expertise, sufficient number of clients, and plenty of time. Getting a big enough sample size to really kind of prove your theories, it can be a challenge. Preventing dropout, there's a lot of things that go into planning this out. And then one of the criticism, either imagined or real, is that the program cannot change during the course of the experiment. Once you've come up with a study design, you've got to stick true to it. Otherwise, you kind of risk losing the validity of your study because then there gets too much noise in your data. Other criticisms is that differences in staff skill level can affect results. So even if you have like a standardized protocol or something along those lines, different staff might give like their own little twist to it. And it might be like those little tiny differences that can cause the variation in your data. Also, results might not be generalizable to other times, locations. So despite our best efforts to come up with a true experiment with internal validity properties, without externalizability, we can imagine the kind of problems that we might see and face. There's also threats to professional judgment or institutional knowledge, because through creating a true experiment, you can imagine that the part of the purpose of it is to try to take out clinical judgment and have more protocol-based treatment. In a lot of ways, research should inform our practice, but one of the challenges that you see between research and practice is that in an experimental environment, we try to get rid of clinical judgment, which can be a potent ingredient to change. And so there's a little bit of give and take here. Other difficulties in agency-based research is that inaccurate perceptions that new treatments are always better. Sometimes there's new treatments that come out, and I've recently been to trainings on new protocols, and I personally don't always view the newest thing as being the best. Sometimes there's the tried and true things, and there's always a little bit of resistance to change. And also that we've got the last bullet point here is that clients do not want to be experimented on always. And typically the people who are more likely to give informed consent are probably the ones who have less clinical severity. So then you get an overrepresented sample of clients who have less severe symptoms, maybe even at baseline. So the limits of the true experimental design within itself are that true experiments do not identify causal mechanisms that cause a treatment to be effective or not. All we can really show for sure is correlation, not necessarily causation, unless we've got a sufficient amount of longitudinal data to really show that there is a causal relationship between our variables. And true experiments do not guarantee control over conditions present in an experiment as it progresses. So despite researchers' best efforts to have clinical control over all external and internal environmental variables, there's always going to be some type of influence on the data that can kind of contaminate the data or make more noise in the data than we would really like to admit. So to compare a true experiment to quasi-experiment, a quasi-experiment is one where we may be able to rule out some of the threats to internal validity, but there's no random assignment in quasi-experiment. So this is that balance between internal and external validity. Quasi-experimental designs often have more external validity, but less internal validity. So some examples here are non-equivalent control group designs, where there's non-randomization version of a pre-test and post-test. Time series design, which is a longitudinal study of people before, during, and post-intervention. And then ex post facto control group design, which is a comparison versus treatment group, not randomly assigned, and typically implemented after research has occurred. So you can imagine in each of these designs described by the textbook, there's good evidence for the externalizability of the study's finding, but probably less internal controls that a researcher may have over the study design. So some non-experimental designs can be a one-group pre-post test. There's an absence of a comparison group and compares post-treatment data with pre-treatment data. In this, you can imagine everybody in the group gets the intervention, and all that we're doing is a pre and post test, which can give us strong ideas about correlation. We can show if our intervention was correlated with a change in the outcome variable. If everybody in a class gets an intervention for improving study habits, we can see if there's a correlation between the implementation of the study design and improvements in grade afterwards. but that doesn't control for all the other variables that might have led to that improvement, such as the measurement reactivity or Hawthorne effect, where people improve their grades just because they know that they're being monitored. There's also an after-only design, which is a cross-sectional group design. So with different groups at the same time, focuses only on post-intervention data, but does not evaluate the validity of the intervention. There's multiple groups, but they all get the same intervention, and we're just measuring them at that one post-intervention time point. And then there's also the static group design, which is just two groups, no random assignment, and no pretest or baseline. So just two groups, one point in time. This is one you probably won't see as much in research, or I haven't seen, but still a good term to be aware of. So implications for evidence-based practice: when you're reading through the research articles, consider the study's randomization process, its sample size, and attrition rate. Anytime you're looking through a research article, you'll see information about the sample. Typically, it's just titled sample, and you can pull it up and look at it, see was it a big sample size? Did a lot of people drop out? And when you're looking at the study's methods, you might also want to look at it, see if there's randomization. So if there wasn't randomization, or if they said there was randomization, but when they described their methods, you might see that, okay, well, this wasn't really randomization. This was kind of like more of a convenience. So it's good to be an informed consumer of the research and really see if the authors are holding up to the claims that they're making. Also, an important concept is meta-analysis. So this is quantitative methods for identifying patterns and findings across multiple studies of the same research question. So you're looking at the larger, broader body of research and taking all these multiple studies and comparing them to one another. So this is non-experimental, but it gives a lot of power to us by looking at the whole body of literature and comparing multiple studies of a similar type of intervention or a similar type of study. This can result in more generalizable findings than others in an individual study. So as you can imagine, if we looked at all the research that was out there on a cognitive behavioral intervention for depression, multiple sites, multiple populations, multiple time points, et cetera, we could do a really big meta-analysis of all that data and statistically show that this is an effective or an evidence-based intervention for the treatment of clinical depression. So regarding diversity and multicultural issues, it's important to take note of the external validity of the study, especially those with specific populations. And with those diversity issues, there are examples where a certain intervention might work better with a certain ethnic group, racial group, socioeconomic group. So for certain groups, maybe like a spiritual component is more important for their protective factors or their resilience, versus in another group, it might be fine just to specifically focus on cognitive components of their well-being. Some ethical considerations is if we are going to be doing a study and people are randomly assigned to one group, whether it be an intervention group or a control group, researchers have to kind of think what happens if somebody's assigned to a control group or a wait list but needs treatment. Is it ethical to really postpone treatment in this situation? Some people might argue that it might be for the betterment of research or the betterment of professional practice. Other people might say that it's not really ethical for us to delay or postpone treatment in some situations. Also, another ethical consideration that you'll see from the Milgram study, if you haven't watched the video already, is people question whether or not it's really ethical to lie to research participants when administering a placebo or a new treatment. And this has been a topic that's been around since the beginning of social science research. Is deception ethical, and to what degree? Certainly you can imagine situations where we need to provide some deception to control for placebo or to investigate placebo. But I think the question that I would want to ask myself is the deception going to lead to any kind of harm to the client or foreseeable kind of damage? And do those risks outweigh the benefits of not providing deception or not improving our research methods?